at 12 at the hospital board. We do not have a quorum today. There's 4 of us. However, according to our bylaws, it says in order to obtain a quorum, this is section 4.7, the board of directors present by majority vote may assign voting privileges that meeting only to one ex officio director present, and to be counted with establishing a quorum. And so we need 5 for a quorum. And so I'd entertain a motion. We have 3 ex officio members here. We have Larry Putnam, Lori Johnston, and Laurel Chambers. So
I'll move Larry Putnam for ex officio vote for the day.
okay, thank you, Jim.
I'll second.
Thank you, Lloyd. Any other discussion?
I have never voted in a hospital board meeting in the 32 years that I have.
Well, there you go.
This is quite unique.
It is. This doesn't happen very often.
Here. let me get you-
All in favor?
Aye.
Aye.
Any opposed? Okay, Larry, you're now a voting member for this meeting only.
Thank you. What's that?
Don't let it go to your head.
So we have established a quorum now. Our first order of business is any public comment. Do you have anything else? Larry, do you have a comment?
Well, I just had a couple questions. There's been a swap, a change in the hierarchy of the hospital and the clinic. And I was just wondering what the added administrative cost has been prior to this grant process and what we have now. I'm looking at it, I think it's going to be a considerable change. And I was just wondering if anybody had any idea about what that would be or whatever. That's just my one comment was, because that's what we're going to be looking at as a cost to the 2 departments, let's call them departments about.
The health center
Health
and the
center.
hospital.
It is that in the future, we're going to have this increase of cost sitting on our heads.
I couldn't tell you any exact numbers because I don't have those in my head right now.
Okay.
I don't know if somebody else could.
Yeah, I
give a
can't
better-
supply the numbers, but I can tell you actually, it's, in terms of number of personnel, it's 2 for 2. We no longer have Steve Carty, and we no longer have George Bailey. And we've in place put 2 interim CEOs in place who are actually working very hard on cost containment and cutting a number of expenses out to get us in a better position.
Well, see, my point is prior to this grant process, we had one board and one hierarchy over the whole system. And now we've split that system and we have 2 sets. And that, to me, seems to cost something.
It does.
You know, and that was what I was looking at, because in the future, we're gonna have to support that. Okay, that's gonna be like insurance, it's gonna be right off the top that comes off of our operating. So that's what I was getting at.
Yeah, I mean, it does cost something. By same token, the grant gives us more money than it costs to cover
Right,
those
but
costs.
the grant doesn't last forever, and the grant has on its merits, it sets up the system, it supports the system for, I'm just gonna say 3 years, and then there's 2 years after that you're contractually obligated to keep that fiduciary support. And
But-
and
But
No, I
that's
don't
not
think
true
that's
about the
correct.
grant.
Cindy?
He's talking about the elevations.
It's been, we've had this grant, and it will be, it's like an annual grant, it's been here for 30 years, from the feds, for the health center. So that's not gonna go away.
Well, no.
May
No.
change.
No. Cindy, let Cindy go ahead.
Hi, Larry. I'm Cindy Sturgard, interim CEO of Health Center. So those are really good questions that you have, I think. And it's always great to be in a community where the community's engaged, right, and ask good questions. So on the health center, what the health center has now is a 3-year New Start funding that allows them to get ready and set up at $650,000. And so every year we report in and they look at everything we're doing. Are we meeting the needs of the community? And then it will continue on unless there is reason that is very significant, meaning that you have criminal activity here, that they would stop that. So I used to direct a health center that has been around, it was the second oldest in Montana, it's been around for 25 years. Very large in southwest Montana because the needs were very large. There's never been any problem with that, and so every year you continue to be accountable for that and show what you're doing. So that is not a 3-year ending. In that organization called Mineral Regional Health Center, which is the clinic, also houses the innovation grant. That grant is separate from the health center grant, and that is a 3-year pilot which will end. And that everyone who works for that knows that they will not have a job at the end of that, okay? That's different than the 650, which is about providing clinical, medical, oral health services. So that's how the money works, if that's helpful. And I'll let this board address your other questions, but
That was.
Those are good questions.
Well, if you go way back in history too, I mean, it was a federally certified rural health center as a department of the hospital before the FQHC was formed, what, about a year ago, whatever.
October 6th.
Yeah.
Finally, we got the opening date.
Right,
October 6th.
right. Yeah, October 6th of 2012 was the official opening date of the FQHC. And, you know, those expenses are all over there now. I mean, you know, and you had a manager at the federally certified rural health center, just like you do there. And I would say, I guess, about my salary, you know, when I talked about that with the board, I would openly talk about that. I said, if you want me to come here to help you, you know, I'm happy to do that, and I will do that for exactly what the previous CEO was doing. I mean, that's our arrangement. I mean, so there are not a lot of additional expenses that I can see, you know, to operating like we did before, you know, even 5 years ago. Yeah, roughly the same. I mean, roughly the same.
Yeah. I just have those concerns because I've heard a lot of people wondering.
Well, maybe we can, is it okay if we go ahead and do this CEO report?
Well,
You
Leona
have
has,
other-
Leona
I'm
has
sorry,
something
you're
too, so
still in
let's,
public
Okay, so,
comment.
yeah, but for right now, I just wanted to put that out on there and I can come back later and try and get it pertinent.
The 2 reports, if you can wait, the 2
Yeah,
reports. will help
we'll address,
shed some light on that, too.
we'll address all of our plans in terms of getting these costs and out of the system, you know, and stuff, or what we're doing to address these costs, you know, that are very burdensome to the community. We understand that. Cindy and I will talk about that in a few minutes if you can hang
Yeah,
on.
but as the comment is at the start, you know, you kind of, the public comment is at the start of your meeting, and it's hard to know what's going to be covered exactly in the meeting.
Sure.
To address the questions you have when you turn in with them, so, you know, I'm just putting it out there. If it's addressed, that's fine, it's just it's a concern from people when we see the people look at 2 complete boards set up, and, you know, everybody that's lived here for more than 3 weeks knows how tight the money is.
Can I get your name?
Larry Price.
Thank you.
okay, go ahead, Leona.
Under old business, this ER coverage, when you went into executive session, was it discussed at all? I know you can't say a whole lot about people, but
Where-
as a position.
where are you looking?
Under,
In the minutes?
yeah, under the ER, looking for a medical director that could handle patients in hospital and rest home and also cover the emergency room 8 to 5, Monday through Friday. So that the patients in the clinic would have full-time service and not have to sit for hours.
I think it's probably something that's gonna get more addressed in Larry and Cindy's report too. That's something they're working on. I mean, we didn't reach any decisions at all, and we're relying on their expertise to help us make that work, so.
Okay, that's all I got.
That's the goal.
Huh?
That is the goal.
Thank you.
Thank you for your comments, and let's move on to our approval of minutes. Did everyone have a chance to look at the board meeting minutes from September, or October 29th? or any changes?
I'll move approval.
Okay, thank you, John.
I'll second.
Thank you, Lloyd. All in favor of approving the meeting minutes for 10:29?
Aye.
Any opposed? Okay. Next, we have our finance committee meeting minutes from the same date on the 29th.
I didn't see them.
No, I didn't either. I'll move approval.
Okay,
Second?
thank you, Jim. All in favor of approving minutes for finance committee?
Aye.
Aye.
Thank you. You voted too.
Oh, I'm just not used to doing that at all. You'll have to remind me.
Okay.
Sorry.
Okay, any opposed? All right, minutes have been approved. Do we need a vote to move the Health Center Board report up?
Yeah, you do.
We want to move that from the other reports now so that we're not keeping Cindy here longer than she has a lot of work to get done, so.
I'll move, we move the Health Center report up on the agenda.
I'll second.
Okay,
And
favor?
we might try to do this together. Is that all right?
That's fine, sure.
That's fine.
Make mine a little shorter.
All in
Okay.
favor of the agenda change?
Aye.
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 Okay. Okay, so I'll turn the time over to Cindy and Larry to give us an update on the health center and the,
Well,
I'm assuming
think-
this is for the collaborations and everything too, as what's
Exactly.
going on.
Exactly. I mean, you know, hopefully everyone knows Cindy. Cindy is the interim CEO at the health center, and, you know, I'm Larry Putnam. I'm the interim CEO at the hospital. And, you know, our goal we've been here both about a month, you know. This is, next Monday will be the month, you know, the first month. And, you know, one of the things that this board did with me, and I think with Cindy as well, is, you know, one of our goals this first month was certainly to open up the lines of communications with our own employees, with the medical staff, with the community, and most importantly, the community, because they really drive what's needed here in Mineral County in terms of healthcare. And we've done these town hall meetings, you know, the last, we finished them day before yesterday, on Tuesday and Wednesday. We went to Alberton, Superior, St. Regis, and DeBorgia, and spent time with each one of those folks in kind of laying out what we were about and getting a feel from the community as to what levels of healthcare are needed, you know, in the county going forward. Well, and, you know, I'm kind of known as the bald-headed bean counter. That's my nickname from other assignments. And so I kind of took the lead on cash flow for the hospital. I'm speaking only here on the hospital side, but I think we share the same kinds of situations. I mean, we are in deep weeds. I mean, and we laid that message out there in each one of the communities that we visited. We certainly, it just in very round numbers, and we don't have it pegged exactly because it's hard to get our arms wrapped around it, you know. But I think it's on the hospital side, it's roughly, you know, probably roughly 40 to 50,000 a month. I would say that you're hemorrhaging in cash. We have 23 days of cash on hand, which means that Stacy is over there not sleeping appropriately. Every time twice a month in the hospital, we have a $200,000 payroll in terms of payroll. And then that's twice a month, that's $400,000. And on the payable side with contracts and supplies and all of that stuff, you know, it's 170,000. It gets a little complicated here, but you know, there's 170,000 plus. There's some other stuff, you know, that flows through the payroll system, but actually it's paid on the payable side. You know, the bottom line is there's a lot of money that it takes, you know, to crank that cash and keep and we're not keeping up. The cash balances, the payables balances are growing. And so, you know, we've laid that message out there, and, you know, the only way that I know how to do this, and Cindy and I have had a lot of discussion about this, is to just go through it line by line, and we're getting very close there. We wanted to meet this week, which we did, with all of the providers, and make sure that they're the key piece in any healthcare operation. And that's why we have to collaborate, you know, very closely. Those providers are very key to us, and how we cooperate and staff the hospital and the clinic is just absolutely critical. And we've gone through our first round of very preliminary discussions with them, and hope to, by a couple more weeks here, have a very firm handle on how the providers are going to be staffed in both the clinic and the hospital. And, you know, that's basically where we are. You know, these questions about, certainly about, you know, we would agree that there's a lot of stuff that we just can't afford. You know, we'd like to have some of this stuff, but it's going to be a line-by-line analysis. That's, you know, going line by line in analyzing that. And it looks like, we'll talk about this later in the meeting with the hospital board, but, you know, we'd like to, around the, 19th or 20th, I think, right around that period of time, Lloyd keeps asking for this, when are you gonna know? You know, when are you gonna know, you know, exactly what the revenues are, what the projected revenues are, what your expenses are, and how do we get it so that it's in balance and we're with the cash, and that we're not continuing to grow these balances, which will send us into a death spiral in terms of survival of the hospital and the clinic. I mean, you know, we're not going to go. We don't want to go there, and so we need to right-size the organization, you know, to make that happen. And we're comfortable that we're going to do that. We're just not exactly quite there yet. And we've been working about 12, 13 hours a day to get there, and you know, we're going to get there, but we're not just quite there yet. One other comment, and I'll shut up because I do talk too long. In this mix, it's kind of a tricky thing. It's kind of a strange thing that, yeah, we are cash short. But we've been talking to a couple of surgeons. Well, McClelland has been here for quite a while, an EMT. Also, Dr. Gardner. Where John has been working with Dr. Gardner for a while. He's a general surgeon from the Polson area, and we're going to get him over here and working in combination with Dr. McClelland. So, you know, we'd much rather address this with revenue than expense, you know, decreasing expense. So if you have kids, or if you know of families or grandkids that need ear tubes or TNAs, you know, tonsillectomies and adenoidectomies, very routinely done with my grandkids anyway. Be sure to keep in touch with the hospital. We're shooting for around 15th, 20th, I think, with Dr. Gardner. Dr. McClellan, though, is already seeing patients, you know, for ear tubes and TNAs and other kinds of ear, nose, and throat procedures, or just clinic visits with him. And he's had a very successful practice here, lives down at St. Rita's, great guy. So we're looking at some revenue opportunities as well. And then also, at every one of these town hall meetings, we've had questions about how you can help. How can we help? How can we help the hospitals? Well, the thing you can do is use our facilities. Use our facilities. Please use our facilities. Just a few more acute days, one or two swing bed skilled patients, you know, which are reimbursed very well for us from the Medicare side because we're cost-based reimbursed. We had an admission on the assisted living unit last weekend. We were thrilled that we had that. We're working on another admission with a couple. So Cliff says that that's the first couple that they would have, if we're successful in that effort, the first one in 10 years that's been in the assisted living. If we do attract that couple, we'll be at capacity on the assisted living side. But we need to be there in order to make the numbers work with the cash flow. We continue to fall further and further behind if our volumes, and it's the same on the clinic side and stuff. So I'll let, you know, I think Cindy has a much better take on this than I do from the clinic side. She's an absolute expert on the FQHC side, and you know, I'll let her.
Says that every time. It's like I'm shoveling money in his pocket.
Yeah.
I'm like, God, what? So I have the privilege to come here and work in this beautiful part of the state. I mean, it's the 65-mile ribbon of Montana that is so pristine. It's just quite beautiful to be here. So in the town hall meetings, we did this all the way through, and it was wonderful to see the different needs in all of those communities, right? Community health centers or clinics are about the needs of the people in the community. How old are the people that live here? How many people? How do we do it? And how do we do it at the most cost-effective rate possible? The thing besides what Larry said, how can you help us? The real thing at a clinic side is when something goes wrong, please tell me ASAP. And that's the other thing, the
Same in
message
the
we've said to people is please let us know. And people have been very good about that. We know there's lots of problems at the clinic side I'll talk about, systems-wide, right? And we've started to put some things into place as soon as we can, which is how to take care of patients. So we are losing money as well. Now, I think, Larry, your question was great about, what about 2 boards, all this stuff we had before, why did we have to do that? Well, and I wasn't here, right? You guys were here, so I'm not saying I know what happened here, but from an outsider's perspective, when I came in here and saw some of the books from previous years, there was always a loss at the clinic. Now, how it was structured is it was the department of the hospital, so we didn't advertise that, right? Hey, the clinic's losing $300,000 this year. Hey, the clinic's losing $250,000 this year. But they were losing money for a number of years, and so the idea isn't a bad one. I don't know how it came to be here, but from an outsider's, the idea is not a bad one. Can we convert to an FQHC and get a stable source, which at this moment in time, because if you would have done it 10 years ago, it wouldn't have been $650,000, but at this moment in time, you get $650,000 to offset your uninsured, and most of us who live in Montana, it's hard for us to pay full cost for healthcare, it just is, okay? So it's to help offset that so people have access to care. So the idea behind putting it in as an FQHC, I mean, from an outsider coming in late in the game, doesn't sound too bad. When you do that, the rules change from an RHC to an FQHC. Trust me, the RHC had rules. Now it's a little bit different, and one of the rules is you must have a board that has consumers on it. You must have 51% consumers. You have to engage the community because the decisions being made, so it's different than the public hospital, right? The public hospital says we're gonna have public meetings, we're gonna have public members, we're gonna elect them. FQHCs say you're gonna have a board, but on your board, you have to guarantee the 51% are consumers. And so we do it differently, and we do some different reporting than you did in RHC. But trust me, RHCs were doing reporting as well. Ours is just a little bit different. We know that there was some leadership issues here in the past. Neither one of us were here, we don't know the details, but coming in, we know there was some of that. So our job is to take care of that, okay? But in that process, the billing issues, especially on the clinic side, got really messed up. And I am on, Monday will be my 1 month, 2 days. So I haven't been here much longer than him.
2 days longer?
2 days longer.
Should have it fixed by now.
That's right. So we are just getting there, right? I found out some more things yesterday that after my board meeting, that I just about went through the roof on, okay? But now we know, so we can fix it. When we don't know, we can't fix it. So our main message is please tell us what's wrong. If it's a billing issue, if you have a concern on where's that money going, what happened to that money, how does that money work? Please let us know. We will tell you. We will tell you what's happening there. Our main concern right now is working on how do you support, from a medical provider standpoint, how many providers, what type of providers should be here? What's the quality of providers should be in a county of 4,000? Spread out. And then how do we make it legally work so that the clinic runs efficiently, effectively, and that the ER 24/7 is covered? So we're right, like Larry said, in the middle of those discussions. We could be really mean and decide And Larry could too, and go, we don't care what you do, we're gonna hire our own physicians over here, and we're gonna load up our costs, and we go, we don't care, because we don't like you, we're gonna hire ours over here. If we both did that, we'd both be shut in about a year. We can't operate here unless we are operating hand in hand in hand, every step of the way. And at the same time, maintaining the regulations, keeping the costs as low as possible, and keeping the community informed and engaged as we go through this process. Because, right, I'm interim. I'm gonna go home to Butte, I hope, someday. I love it here, but my real house is in Butte. My job
Mine
is
is in Helena.
to work with these guys, and we have the luxury, which I've never had before, of having a number of board members that serve in a capacity of service on both boards. So I feel like we have that already built in here. Some people might think that's a conflict of interest. Well, we follow the conflict of interest rules. It's quite apparent, people tell us, in a meeting what they're doing. But I have never walked into this size of a community and have seen boards work as hard as these boards are working. It is the most amazing thing I've seen here. That was one of the reasons I said I'd come. The board's very engaged, the community's engaged, which means we have the ability to make the changes, create the improvements, to keep it sustainable, and to have people like you that come and ask those questions, right? So that we don't get too lazy and think we got some show going on here, okay? We don't. This is a really important part of the community. Healthcare for our kids, and mostly for when the older I get, or when I continue to get old, and where am I gonna live out my last days, right? Critical,
Getting close.
critical
Getting
issue.
close.
So, I'm happy to be here, and I'm happy to always, we literally have already spent 3 hours together this morning. So, we're working all the time together, and I appreciate being a guest at this. I'm not a part of this meeting, so I appreciate Amy and the board for letting me come to share. what's happening.
Maybe
Well,
one thing, one more thing, and I always have to have one more thing, talk a little bit more, but we both made the point that nothing was done in the past that was illegal or improper, or no embezzling of funds.
No, the money is all properly accounted
Right.
for.
It just was, it was put in the wrong bucket, it was put in the wrong accounting column, But no cash is missing, no dollars, no property is missing, anything like that. That has not happened. And we certainly heard that when we first came, that that was happening. That was the rumor, the rumor around the communities. And we just want to make that clear that, that is not the case. That is not the case here at all.
My question is more specific about, so we were looking at making sure contracts and things were in line and set up so that we were gonna be able to get billing between both entities. How far along is that? And my other question was about how long until we can get some proposals for our ER coverage issue, and what are some of the solutions to that?
We're doing that daily. We just had 4 meetings this week around it, and I just met with my board. We had a board meeting yesterday, so they know that we're in that process. Our hope is that by the first of the year, now, that's our hope. We may hit some snags, it may be a little bit later, but our hope is to hit that by the first of the year, that the contracts, the employment agreements are separate, and that we have now, we ran into a couple things that these aren't big hurdles, but that's why we're meeting with people, is to really understand that. Our commitment I'm speaking for you today, but our commitment is that the people, we have Laurel in here right now, our core providers, we've had discussions to say, we're hoping you're sticking with us, right? We can't make anyone stick with us. We're hoping you stick with us because you've been committed to this community. In the clinic, this is the quality level we want delivered. Are you in agreement? Those are the discussions we had. In the ER, 24/7, this is the quality. Do you have the skills, number one? Do you like ER? Okay, ER is a different ballgame than clinic. So you have to have the competency and the
Always a tough
desire
one.
to do that. That was our initial discussions. We just put the calendar together for the second round, which will be in the 2 weeks of December because of people being in and out. And then we hope to have the agreements. We'll be going, I mean, I'll be talking to my finance committee meeting Monday, and then we have a bunch of meetings set up on our board second week of December. And we're gonna walk through these in parallel to the discussions we're having from the operational side.
You're confident we're gonna get there?
I am totally confident we're gonna get there.
Are we gonna have any shared employees at this point? It was such a tangled mess
No.
about
No,
No,
absolutely
50%
not.
here,
Totally,
20%
that's,
here.
no, no.
Okay.
We're
Absolutely
that's
not.
what we're doing.
Okay.
We, as the clinic, cannot legally do that.
Right.
Now, we could subcontract back and a whole bunch of other stuff, but given the history, we are gonna start clean and clear. There wasn't anything illegal in how we did that in the past. It was how it was, how they were written. The practice of how it was done and how the money flowed was okay. The agreements were not written.
It was as if there was nothing down on paper.
Yes. Yes. So, yes.
And that, and to be real clear, when you say no shared employees, that doesn't mean a particular individual may not have a contract with each
Right,
entity.
Exactly.
But they aren't gonna be, one entity's contract isn't gonna function for both entities.
Right.
Very
Uh,
good, thank you.
yeah.
Right, thank you. Yeah, exactly.
That's exactly what we're doing. So, in theory, just so everyone knows, we could have, I'm just gonna use Laurel because you're in the room instead of, so Laurel could have a contract with the clinic to work in the clinic 3 days a week. She then could have a contract for ER in the hospital and work 5 shifts a week for the hospital that are different, not clinic, but they're different, right? That could happen.
She gets 2 paychecks, but, you know.
But together.
It's
they're
all
The effect
very
is the
separate.
same. The
It's
effect
kept
is the same.
separate.
Two
The
separate
employee
paychecks
has
from
the
two
work they
separate
want.
employers, that in her mind and her family's mind is great, you got one salary, right? But we are following our legal proper
Nanny,
channels.
please call extension 302.
That might
Nanny.
go.
And on the hospital side is, well, Cindy's process, we have to get this process with the medical providers straight first. And
Absolutely.
And then we'll step through on the hospital side, because it affects everything else that goes on. And both of us are working very hard on the cash flow issues and the operational issues, going through this line-by-line analysis that I'm talking about. And Lloyd's question was earlier, you're going to set a meeting date for December. I've had boards in the past that didn't even meet in December, but I think it's going to be very important that you meet this year in December.
Yeah.
And at that board meeting date, hopefully it can be around the 19th or the 20th. You're looking at those 2 dates, and we'll sync those dates between the 2 boards right about the same time. And at that point, you will have, we hope.
Yeah, it's
We
our
hope.
goal.
But that's our goal, is to get that done. And so you can review our work plan going forward after the first of the year, and make some decisions about that December board. That's
Okay.
that's the way we've been working. Does that help? Does that help?
It does, I just want to make sure it's moving forward. I mean, just to hold your feet to the fire to make sure it's moving forward.
You're doing a good job.
Gotta ask.
We're with you.
Just ready to see
She'll
some
probably call
results.
you Monday to see how you're doing.
And from the leadership perspective, they are right on track and they are working very, very hard. We have had more direction, and support from them, which is great to have 2 great interim CEOs to really work with. So I think it's working very well.
Good. Are there any other questions about collaborations or anything with the health center? Or something? Okay.
Are the boards giving you everything you guys need?
I had 100% attendance at the clinic board meeting yesterday. I almost fell on my face. I've been doing boards for a long time. It's rare to get 100%. Just human being schedules, are tough. So it was kind of a profound moment. I'm like, wow, it was great. So from my side, it's been very impressive. Thank you all, and I appreciate being
Okay,
able
thank
to
you, Cindy.
participate. Nice to meet you.
Okay, let's move on to our Mineral Community Hospital reports. The first up is our Finance Committee report.
Thanks.
With a mouthful of cookies.
Yeah. I think the other day I had crackers, so. Okay, see if I can. The net loss last month for October was 31,600. September was 54,550 loss. So that's a 13,000 less of a loss, which is going the right direction, but definitely needs more improvement. The revenue was unfavorable by 40,000. The operating expenses decreased by 15,000, which is good. And the charity care was 9,600.